Baby girl Stevens is a 2-month-old 38-weeker presenting with extending feeding times, which used to last about 10 minutes that are now lasting 45, and feeding intervals that used to be every 2 to 3 hours that are now about every 4 hours. Her mother, who is acting as her representative, states that she notices times where her baby sweats and dozes off while eating. Mom states that there are also times where she looks startled, throws her arms out, tenses up, and takes a gasp for breath. But she denies noticing any cyanosis during these episodes, and after feeding, her mother denies any vomiting and states that she burps well and rarely spits up. She also denies noticing any changes in the patient's urination or bowel movements. Mom denies knowledge of any birth complications during or after her birth, which was performed by a midwife. Baby girl Stevens was born at 6.2 pounds and 43 centimeters, and her past medical history is positive for 1 URI and no immunizations at this time. All other of the review systems that were reviewed are normal. On physical exam, the patient is afebrile, tachycardic with a heart rate of 175, tachypnic with a respiration rate of 58, but she is awake, alert, and cooing during the exam. Her respirations appeared mildly labored, and they were associated with accessory muscle use and subdiaphragmatic retractions, and on auscultation you could hear scattered crackles bilaterally along with a holosystolic murmur at the left lower sternal border. Her heart rhythm was regular and normal S1 and S2 sounds could be distinguished, and on palpation there were no notable lifts, heaves, or thrills, but her pulses were 2 out of 4 throughout. It is noted that the patient's eyes are upward slanting and the nasal bridge is depressed. She is also below the 50th percentile in weight and height, and all other physical exam findings were appropriate for this patient's age. Based on her tachypnea, labored breathing, exhaustion and sweating while eating, poor growth, holosystolic murmur at the left sternal border, and the weak pulses, I believe that this patient has a ventricular septal defect. It is possible that the patient may have tricuspid atresia or truncus arteriosus associated with her ventricular septal defect, but her mother's report of an uncomplicated birth and lack of cyanosis during the exhaustion episodes or after birth allows me to rule down these defects. Since I cannot fully rule out either defect, I would like to order a chest x-ray to look at the size and presence of the main pulmonary artery and the size of the aorta and its direction of the arch, and the size of the heart in general to observe for truncus arteriosus. I would also like to use the chest x-ray to help rule down tricuspid atresia, depending on the presence and severity of any right atrium enlargement. Pneumonia is also on my differential due to the bilateral crackles on auscultation, so I would like to use the chest x-ray to also note any presence of infiltrates. Along with that, I would like to order an EKG to look for any indications of right or combined ventricular hypertrophy to further rule in or rule down truncus arteriosus, as well as rule down or rule in tricuspid atresia, depending on if there is presence of right atrial hypertrophy. I would also like to order an echocardiogram to look for the location and size of the ventricular septal defect, which I believe is the problem, while noting if there is a presence of the tricuspid valve for confirmative information about tricuspid atresia, if it's present or not. I would like to receive a surgical consult on this patient following her test results in order to schedule the patient for surgery once a diagnosis is confirmed. Based on the results of that consultation, we can begin the patient on medications to help with her symptoms while she waits for surgery, or if surgery is deemed unnecessary. Or we can, if it is deemed unnecessary, begin a regimen until she grows out of the ventricular septal defect. On physical exam, it was also noted, as I had stated, that the patient has upward slanting eyes and a depressed nasal bridge. Based on this finding, I would like to have a deeper conversation with the mother about any family history of Down syndrome, and I would like to run a genetic test if the mother agrees for trisomy 21. This condition would coincide with the suspected diagnosis of ventricular septal defect, as patients with Down syndrome are more likely to have these defects. If the results are positive, I would like to provide the mother with some education on Down syndrome and also offer her connections to support groups for families of children with Down syndrome. Aside from that confirmation, or aside from just confirming the patient's diagnosis, I would like to schedule the patient with an appointment to begin her vaccination schedule, since the mother has agreed to completing her daughter's vaccinations. And I would also like to schedule the patient's 4-month checkup in advance. And the final thing that I would like to do is just inform the mother that I will stay in communication with the surgeon consulted to determine if a sooner follow-up is required to start those medications or whatever else we need to do.